Welcome everyone back to Pulm PEEPs. We're really excited to be going into a new episode today. We're going to return to our Pulm PEEPs and BMJ Thorax collaboration, and I'm really excited for us to get started with this. As many of you have listened to our first two journal clubs with Thorax, Thorax is one of the leading journals in pulmonary and critical care medicine. It's the official journal of the British Thoracic Society and regularly publishes cutting-edge research that helps shape our field. In addition to advancing science and clinical care, Thorax is also deeply committed to medical education, which Dave and I love, which is a big reason we're glad to be working with them again. Once again, we're joined by Dr. Christopher Turnbull, Associate Editor for Education at Thorax. Chris is a respiratory consultant and honorary researcher at Oxford University Hospitals, and his work focuses on sleep-related breathing disorders. Chris, so great to have you back on Pulm PEEPs, and we're thrilled to be partnering again with you for this episode.
Thanks, Christina. It's great to be back on Pulm PEEPs and really excited to get talking about today's journal club.
Perfect. I know. I continue to listen to our first two ones just because it's such a great way to highlight different articles sometimes that I may not have in my queue to initially read, but otherwise important articles that I think we should be listening to and reading and being familiar with in pulmonary critical care and sleep medicine. And with that, I'm excited to meet our most important guest today. We're joined by Natalie McLeod, who wrote the BMJ Thorax Journal Club article for March 2025 issue. Natalie is a resident in respiratory medicine and is currently doing a clinical fellowship in sleep and ventilation at Oxford University Hospitals. Welcome to Pulm PEEPs, Natalie.
Thank you so much for having me. Pleasure to be here in this collaborative podcast.
Yes, so looking forward to it. And really excited to ask you some questions today about the articles that you selected, as well as go through some general three themes of each of them. And before we get started with each specific article, Danny, I'd love to hear about your overarching goal in selecting these four articles. Was there a common theme or educational value you were hoping to highlight?
Yeah, so the topic I chose for the March Journal Club was sleep and ventilation, focusing 2 studies in OSA and obstructive sleep apnea, and 2 on non-invasive ventilation in hospital settings. And sleep and ventilation is an area of respiratory medicine that I feel sometimes is a bit underrepresented. So I really wanted to use this opportunity to highlight some of the really interesting and exciting work that's taking place in this field.
Well, I'm so glad that you picked these four articles to talk about, Natalie, and couldn't agree with you more. I really do think that, at least I know Dave and I on Pulm PEEPs, we really haven't had the opportunity to highlight important sleep medicine topics. So this is actually the first episode where we'll be focusing more on sleep medicine in more detail. So for those listening today, I hope you enjoy this, and I hope this is the start to bring in a little bit more sleep medicine content. And I know the first study that you selected, Natalie, sorry, I'm going to repeat that one. And I know the first study that we're going to be talking about today, Natalie, conducted an individual patient data meta-analysis of 36 RCTs to evaluate how CPAP affects blood pressure in patients with obstructive sleep apnea. And this study used an individual patient data meta-analysis instead of the more traditional one that many may think of. And Chris, I'm hoping that you can walk us through why does that matter and what does it add for us as clinicians?
Yeah, certainly happy to. So this is, as you said, an individual patient data meta-analysis, which means that rather than relying on aggregate data pulled from different studies, the authors actually go ahead and get the data from each individual participant in all of the RCTs included in this study. And that's got a number of strengths and advantages by picking that approach. Firstly, I think, and mainly that focus is to add and increase the granularity in the data that they're looking at. Particularly, and one of the things that this article really utilized that to do was to evaluate and look at different subgroups of patients in more detail. In addition to exploring subgroups, they can also standardize the way in which they analyze outcomes and adjust for covariates in a consistent manner across studies. Also importantly, they can account for missing data by imputation, which you perhaps can't do so readily in a traditional meta-analysis. I think there are some downsides to this sort of an approach. Firstly, it pretty labor intensive. So it relies on you being able to get in touch with all of the authors of the original manuscripts and getting access to that data. So that requires a lot of permissions, data access agreements potentially, and then a lot of work in making sure that data is presented in a uniform fashion that it can be utilized for the analysis.
Wonderful. Thank you so much for walking through that approach, Chris. And what I love about the BMJ Thorax articles and the articles that you've selected today, Natalie, that we'll go through, not only are we going to be able to highlight, as I said, some great sleep medicine content, non-invasive interventions as well, but really get to look at different methods used in each paper, which I think is so important for a journal club, right? We want the key result and the key takeaways, but I think this gives a really great opportunity for us to talk through different methods and study design. So, Chris, thank you so much for walking through that and appreciate your expertise. Natalie, I'd love for you to share with those listening today what stood out to you most when reviewing this meta-analysis, and were there any findings that challenged your clinical assumptions about CPAP and blood pressure?
So I think there's been accepted now that OSA is linked to hypertension, but previous studies have shown really the improvements in blood pressure are really quite modest, somewhere around 2 millimeters of mercury. And I think what was really good about the study was its clinical question: which subgroup of patients could gain the most benefit in terms of blood pressure from CPAP therapy? And I don't think that was a question that's really been asked before. So what the Andante collaboration did through a meta-analysis is they pulled individual patient data from 36 RCTs, which was just about 9,500 patients in this data set. So incredibly huge data collected. And they showed that the greatest reduction in blood pressure was seen in those patients with uncontrolled hypertension. And actually, there was little to no change in blood pressure in patients with controlled hypertension or even normotensive patients.
Great. Thank you so much, Natalie. And as Chris said, with this size of a study population overall, by pulling the data, very labor intensive. And I'm interested as a follow-up question, you mentioned that patients with uncontrolled hypertension saw the biggest benefit from CPAP. How do you think this should shape how we approach treatment decisions or talk to patients about starting CPAP?
So I think it's fair to say that there's cardiovascular benefits of CPAP can be fairly controversial, and previous studies have shown fairly neutral results when specifically looking at that question. Now, we know CPAP is a highly effective treatment. It improves sleep study metrics, it improves patient symptoms, and therefore leads to improvement in their quality of life. And we know that CPAP improves blood pressure in patients with resistant hypertension, i.e. those patients who have uncontrolled blood pressure despite taking 3 or more medications. So I think what this study can do is that it can add to that, showing that those with uncontrolled blood pressure not yet meeting that definition of resistant hypertension might also benefit from blood pressure reduction with CPAP. I think it also helps maybe to give us a bit of ammunition when it comes to targeting individuals with OSA and uncontrolled blood pressure towards CPAP treatment. So to give you a real life clinical example, if you had a patient who had mild OSA and had little to no symptoms and had uncontrolled blood pressure, I think I may be more persuaded to counsel them towards CPAP therapy for this added bonus of blood pressure reduction.
That's fantastic, Ali. Yeah, thank you for that. Thank you for this last kind of relevant clinical example about how we can think about things, right? I think in this case, just showing instead of the standard pharmacologic treatments for hypertension, this CPAP could prove to be another clinical intervention that may be necessary in certain patient contexts. So appreciate you walking us through that. And I wanted to also note that the authors commented that neither age nor nocturnal hypoxemia severity influenced the blood pressure response to CPAP. And I'm interested to hear from you, Chris. What do you think this tells us about the underlying pathophysiology?
Yeah, so I think this is a really interesting finding from this study, and probably it's slightly controversial, certainly the part around looking at hypoxemia. So looking at age firstly, when the authors did an analysis imputing for missing data, which they're able to do because of the approach in this study, they did see that there was more benefit in terms of blood pressure in younger patients, suggesting that actually some of that lack of a difference for age in the initial analysis might have been due to missing data in the first place. Then coming on to the more pathophysiological question, is it intermittent hypoxia that's driving the blood pressure rises? I think it's worth thinking about how they looked at that in this study, and they used the measure of hypoxemia as the lowest saturations that patients had over their sleep study. That's perhaps not the best metric for analysing this, and certainly things like the OSA-specific hypoxic burden are gaining a lot of traction in the literature of ways of perhaps better capturing intermittent hypoxemia. And I think also we know from animal studies and human studies that in those models of intermittent hypoxia, it's been found to be linked to significant hypertension, and that's driven by increase in sympathetic activation. We did a study a few years ago now where we looked at patients withdrawing from CPAP and gave them oxygen instead of CPAP in a 2-week period. And we saw that oxygen abolished the rise in blood pressure that they would otherwise have gotten. So really, I think there's a fairly consistent and compelling argument for intermittent hypoxia being the driving factor behind hypertension and obstructive sleep apnea. And I wonder if here, perhaps they weren't looking at it in the most helpful manner.
Thank you so much, Chris. And like you said, this was the methods and study design of this article had really allowed us to have more granularity than perhaps the more traditional method. But as you said, it comes with some limitations. But love the physiology talk. I think it always comes back to physiology and patients at the bedside. So more to just think about from this last question. But thank you for going through that and answering, and based on your expertise, why you thought perhaps this finding was noted. And of course, for those listening today, you're going to get the links to each landmark article that you can go back and read in more detail. But as we wrap up our discussion on this first article that you selected, Natalie, are there any other limitations or unanswered questions you think learners should keep in mind when applying these findings to real-world clinical practice?
I think there are probably two limitations to talk about. One of them was data accessibility. So despite the author's best efforts to try and get hold of all the individual data from some of the studies, they weren't able to. So perhaps there's a bit of missing data there. And the second is about the blood pressure. So there is a lack of consistency of the way the blood pressure was measured across the studies. And actually, very few of the studies used ambulatory blood pressure recordings. And so that opens the results to possibly being influenced by white coat hypertension or masked hypertension. The other point to make with the blood pressure is that there was limited information available about what medications the patients were on for their blood pressure, how many, any dosing changes, for example, that may have taken place over that research period. And again, that possibly could have had some influence on the results that we see. And so this is probably an area where future studies could focus on to really try and tighten up that association between blood pressure and CPAP therapy.
Perfect. Thank you so much for noting those. And I think you bring up some really interesting questions as well as some future directions and future studies. So I don't know, and perhaps you and Chris may be able to join forces and think of something to study in the future as well. So I really enjoyed going through that first journal article, and maybe something as someone who does primarily adult cystic fibrosis and I also do some oncology critical care, may not have been the first article that I would have on my queue to read, but nonetheless, it's so important, I think applicable to all the patients I take care of. So I like that you selected that one. And I want to go ahead and turn over now to the second study that you selected, Natalie, which was also a meta-analysis. This study, though, was looking at hypoglossal nerve stimulation as a potential alternative for treating obstructive sleep apnea, and especially in patients who can't tolerate CPAP. Natalie, what drew you to highlight this paper for Journal Club? And I'm interested, was it the novelty of the treatment or something about the clinical relevance of hypoglossal nerve stimulation in practice?
I think it's certainly the clinical relevance. CPAP treatment for some patients can be incredibly burdensome. And poor compliance with CPAP is therefore, I think, one of the greatest issues that we face as clinicians who look after patients with OSA. Up until recently, CPAP was really the only option that we had for patients for moderate to severe OSA. And therefore, I was drawn to look at some research that was focused on these, what is new devices to the UK, although I appreciate they are more well established elsewhere in the world. I wanted to have a look at what the efficacy of these devices were, but also what the patient's experience and their safety profile was. And that's what the authors of this paper starts to address.
Fantastic. And yeah, I know, as you said, hypoglossal nerve stimulation may be more readily available or more prevalent in different places across the world. And for those that may be less familiar with hypoglossal nerve stimulation, Chris, can you give a quick overview of how the device works and when we might start thinking about it for our patients?
Yeah, of course. So the hypoglossal nerve, as you'll know, is one of the cranial nerves, and one of its roles is to innervate the genioglossus muscle, which is the main muscle in the tongue, and it's responsible for tongue protrusion. One of the causes of obstructive sleep apnea can be collapse at the level of the tongue base in the upper airway. And what hypoglossal nerve stimulators are aiming to do is, by having a device which is surgically implanted, is to stimulate the hypoglossal nerve, leading to tongue protrusion and bringing that tongue base forwards and stopping collapse of the upper airway during sleep. We'll go into, I think, a little bit later, some of the specifics of which patients might be suitable for this, because it's not suitable for everybody. But I think broadly, the patients in whom we're thinking about this is in those with moderate to severe obstructive sleep apnea and those who are unwilling or unable to use CPAP therapy.
Thanks, Chris. Yeah, and some great points I think that we'll get to next and that are important to consider. And thank you for the brief anatomy review. It's been a minute since sometimes some of us probably have thought of cranial nerves. So appreciate you going through that. And I think an important foundation to understand how this intervention may work and why we're talking about it today. So Natalie, with that, can you provide an overview of what the primary and secondary outcomes of the study were? And as a follow-up question already, from your perspective, what's the most clinically important takeaway from this paper?
So this was a more sort of standard meta-analysis design compared to the previous article that we discussed. So it took summary aggregates rather than individual patient data. The authors included data from 30 studies, of which I must note that only 4 of them were RCTs. Their primary outcome were sleep study measures of OSA severity, so the apnea-hypopnea index, the AHI, and the oxygen desaturation index, the ODI. Their secondary outcomes were more patient-focused in terms of their symptoms, looking at their daytime sleepiness and quality of life, which were recorded using standardized questionnaires, including the Epworth Sleepiness Score and the Functional Outcomes of Sleep questionnaire. So what it showed was that these devices improved the OS severity by improving the HI and the ODI in both the short and long-term intervals. And it also showed that there was a patient symptom benefit in terms of improvement in daytime sleepiness and quality of life, again in that short-term period. And so I think these results are suggesting that these devices can improve OSA, although the extent of its benefit compared to CPAP is not known, as there's not yet been that head-to-head analysis. So I think our takeaway message is, yes, these devices seem to work in terms of reducing severity, but their effectiveness as compared to CPAP is still not yet understood.
Great. Couldn't agree more with you after reading this. I think a really great kind of topic and discussion to put out there. But as I think we always say, future directions and future research studies will be more important to help us apply this information and give patient guidance and recommendations. I did want to also take a minute, though, to talk about it in a little bit more detail. The authors comment that device-related side effects, they mentioned malfunction as well as pain, were relatively noted. And Chris, how should that factor into discussions with patients who are CPAP intolerant but exploring alternatives like hypoglossal nerve stimulation?
Absolutely. I think it should feed into those discussions. I think it's important to note that this procedure requires surgery. So that's a fairly major undertaking to do that. And I think before people are considering it, they need all of the information about potential side effects and what the size and scale of the benefit they might get is, so that they can make an informed decision as to whether they want to go forwards for assessment for this.
Great. Yeah. A lot of discussions. Patient-centered care is something I think we all strive for. So a lot of discussions with our patients and letting them know all the great things as well as the possible other risks and all potential benefits as well. And Natalie, I'd like to ask in a similar way, right? If we're seeing a patient who was struggling with CPAP and wanted to bring up hypoglossal nerve stimulations when you're on rounds, when you're rounding with the team, or in clinic when you're seeing the patient, how would you frame the evidence and position as a possible option for hypoglossal nerve stimulation?
I think, as we've already mentioned, hypoglossal nerve stimulation devices are a fairly major undertaking. As Chris has mentioned, it's a surgical procedure just to get the device in to begin with. And so I think when we're considering them, we need to make sure that all alternatives have been explored first. For example, have we tried different CPAP masks, different interfaces? Perhaps in the more milder patients, if they looked at dental devices. And then, of course, there's other options such as tonsillectomy, if that's appropriate, or weight reduction therapies, if that's appropriate. And so I really think as clinicians, we need to have gone through that list of options first before then considering the hypoglossal nerve stimulation devices. And then if we do get a point where we think that a patient perhaps could be eligible for these devices, we also need to think about their suitability in terms of just being able to go through the pre-assessment of these devices. And that includes undergoing an endoscopy examination under sedation to look for that pattern of upper airway collapse that Chris has already mentioned. So it is quite a big undertaking. And therefore, I think it comes further down our line of recommendations. It's certainly not number one. And I think all other therapies need to be considered first before we then start entertaining the idea of these devices from the knowledge and the literature that we have so far.
Thanks so much, Natalie. And I really love the point that you brought up. There's so many other interventions before we would be considering hypoglossal nerve stimulation as a potential option. And I think a lot of times, sometimes patients, when I'm consulting them on the inpatient setting, they're like, I can't tolerate CPAP. And it's so important to understand why and really go through. There's so many new advances and options to wear from masks, right? Because they're like, oh, I can't tolerate this large mask over my face. It makes me feel claustrophobic. I can't sleep. And it's no, there's so many different other devices, smaller ones, the nasal pillows and more prongs type approaches. So something just, when you said that, it really resonated with me to really think about what are we offering? There's so many options that we have. So make sure that we are having those conversations with patients as well if we were going to be talking about hypoglossal nerve stimulation as a potential option. And probably before we move away from this article, which was a great one, I one final question for you, Chris, on this one. And Natalie may have talked about some of the more clinical implications, but any other key unanswered questions or next steps in research before this becomes a more widely used treatment?
Yeah, I think Natalie's already alluded to some of the key areas I think which are needed here. A lot of the data comes from cohort studies rather than RCTs, and looking at the longer term effectiveness of these devices in terms of patient-related outcome measures, I think is also really important. There's also not been that head comparison with CPAP to know if this could be an earlier option in pathways. I think the promising thing is that there are not lots of devices in development, so this is an evolving area, and hopefully we're going to get that evidence coming through in future years to answer some of those research questions.
Absolutely. And Natalie, I love the first two articles that you picked, both looking at sleep apnea and CPAP as well as hypoglossal nerve stimulation. Such important topics and questions to raise. So thank you for selecting those two. I'd like to go ahead and move on to the third article that you selected for your journal club in the March 2025 edition in BMJ Thorax. And this is turning a little bit more towards the use of non-invasive ventilation on two different clinical areas. And the third article that you selected is looking at pre-oxygenation with non-invasive ventilation during tracheal intubation compared to standard oxygen mask pre-oxygenation. Can you tell us a little bit more about the author's study design and the cohort utilized for this study?
So this was an RCT design. It was across multiple centers in the US, and it compared pre-oxygenation with NIV versus standard care, which is currently with pre-oxygenation with an oxygen mask. And they took a cohort of adult patients over the age of 18 who were critically ill and required tracheal intubation. Patients who were excluded were ones that were too unwell to wait for the randomization prior to intubation, those who were pregnant, those were known to be prisoners, and those who were already on positive airway pressure or with known apnea. I think it's important to highlight that the underlying cause of the critical illness could be anything. It wasn't necessarily predefined, although just under half of the patients included had respiratory failure. And due to the nature of this intervention, the study was naturally unblinded. But this risk is mitigated to an extent by having a very strict defined primary outcome of desaturation below 85% between induction until 2 minutes after tracheal intubation.
Thank you so much for going through that with us. And I think the last point that you mentioned is important to note. It was an unblinded study because the team is going to know, are you bringing in a non-invasive machine? Or are you just using standard therapy? So the intervention is, as you said, for those involved is unblinded, but having this strict primary outcome, as you mentioned, was, I think, a great point that the authors included. And Chris, would like to turn to you, just briefly walk us through how non-invasive ventilation works differently from an oxygen mask during pre-oxygenation and why that might matter physiologically.
Yeah, the authors went into some detail in this in the article actually and described the potential benefits along with some of the potential downsides of non-invasive ventilation. And I think the first thing to say is that conventional oxygen therapy or standard oxygen therapy simply works by elevating the FI2, so that's the inspired fraction of oxygen. The authors highlighted that actually, whilst you might be thinking you're delivering 100% oxygen, there are limitations if you have a mask leak, that actually often what's achieved is much closer to 50% oxygen with a standard oxygen mask. When you use NIV, you're using a much tighter fitting mask with high oxygen flow rates, and you can limit the effect of leak, so achieve much higher FiO2s in practice than compared to conventional oxygen therapy. And in addition to that, you've got other benefits. So you're providing a positive airway pressure, which that expiratory positive airway pressure will help to splint open the upper airway, but also will help to recruit lung volumes. In addition, with NIV, you've got an inspiratory positive pressure, which gives you a driving pressure to ventilate the patient, and a backup rate as well. So there's those additional physiological benefits alongside being able to control and minimize leaks to achieve a better FiO2 than you can with conventional oxygen therapy. I think the potential downsides that the authors were concerned about was things like a risk of aspiration, and also the intervention with non-invasive ventilation taking longer. As you can imagine, when you've got critically ill patients needing intubation, you don't have lots and lots of time, and potentially introducing a delay at that stage might lead to worse outcomes later.
Yeah, that's it. That's exactly right. And Dave and I actually have a separate journal club on this trial, the pre-oxy trial, with the authors who we talked about this a little bit more. And I think one of the other slight limitations as well that they mentioned was that kind of labor intensive, if someone is critically ill, bringing in a non-invasive ventilation machine that may not already be in the room, whereas some patients may already be on high flow nasal cannula, which wasn't necessarily included in the study though, but I think just interesting things to think about. But still, this is such a fantastic article that I want us to talk through a little bit more in detail. So thank you for adding kind of the mechanism of how this non-invasive works, Chris, and why that matters from a physiologic standpoint. Natalie, can you walk us through the key results of this manuscript?
Yes, the study successfully enrolled 1,301 patients, which is a pretty remarkable achievement in this sort of study. And the authors showed that desaturation during and after intubation occurred less commonly in those receiving pre-oxygenation with NIV compared with the conventional oxygen mask. 57 of the 624, 9.1% in the NIV group versus 118 of the 637, which equivalent to 18.5% in the standard oxygen mask group, met that primary outcome for desaturation. So it was about 9.4% lower prevalence rate in the NIV arm. Thankfully, cardiac arrests were fairly rare in both arms, but comparisons were not powered for this outcome. However, just to give you the numbers, cardiac arrests occurred in 0.2% in the NIV arm and 1.1% in the oxygen mask group. So really favourable results towards NIV from this trial.
Yeah, exactly right with that. And Natalie, thank you for walking through those results with us. And Chris, you mentioned this earlier already, but I think with this, it's not for those listening and using non-invasive. I think everyone is going to have this concern about aspiration is a concern with positive pressure. Chris, were you surprised that non-invasive ventilation didn't increase the aspiration risk? And how might you think this could shift how we assess risk benefit in real time?
Yeah, so I think it was a somewhat surprising result, wasn't it? But I think it's really reassuring to see.
Mhm.
I think it's worth just mentioning how this was assessed. So this was physician-reported aspiration at the time of intubation, and the rates of reports of aspiration were low in both arms. However, in an unblinded study, that sort of subjective outcome potentially is prone to bias. I think they were able to mitigate that in my eyes, though, by having a couple of other outcomes which looked at related measures. They also looked at the rate of new infiltrate on a chest x-ray 24 hours after intubation, and rates were similar in both arms. They also looked at the level of FiO2 delivered 24 hours after intubation, and that was again similar in both arms. There wasn't a signal carrying through to suggest that there was a greater number of infiltrates in addition to that subjective measure of aspiration. So I think I am pretty reassured by that finding.
Fantastic. Thank you, Chris. And Natalie, one final question for you based on this article that you selected. If you're on the team prepping for intubation, how would you use the findings from this pre-oxy trial to advocate for non-invasive ventilation-based pre-oxygenation for patients?
I think this trial provides really compelling evidence that NIV for pre-oxygenation makes desaturation less likely without that risk of aspiration in this very selected patient group. However, for it to then move to a change in clinical practice, it probably needs some further consideration and perhaps further studies just to repeat these results to show that this would be a safe option for our healthcare systems going forward.
Agreed. I think it would require a lot of logistical changes. And this is something I know we talked with the authors with really getting buy-in from your institutions, from your intensive care units, from nursing colleagues, from respiratory therapist colleagues. I think definitely something that can be used, but it's just going to take discussions and team effort in order to employ this. I loved the first 3 articles so much so far. We have time for one more though. Your final journal article that you selected, Natalie, which was a multi-center RCT comparing high-flow nasal oxygen to non-invasive ventilation in patients with mild to moderate acute hypercapnic respiratory failure due to COPD exacerbation. Natalie, what made you pick this trial for Journal Club, and what potential clinical implications or growing interest in high-flow nasal oxygen I'm going to repeat that. Sorry, it was like too much. Maybe I should just separate the questions. So I'll just start here. Natalie, what made you pick this trial for Journal Club?
A bit like how we've mentioned with CPAP, NIV also can be really burdensome treatment for patients, and failure of NIV is associated with poor outcomes in the COPD cohort. And so the possibility of having an alternative to NIV is obviously very appealing to both clinician and patient alike. So I think that's probably where the interest began. High flow nasal oxygen is something that we use increasingly common in our hospital settings, but it's really mainly in the context of hypoxia or a type 1 respiratory failure. And what this article focused on is using high flow nasal oxygen in people with COPD who have an acute decompensated type 2 respiratory failure and potentially looking at it as an alternative to NIV.
Fantastic. And I think we, as you said, different, probably institutional variation, but I think high flow nasal oxygen is becoming more readily available and more widely used. Glad that you picked this to look at, and specifically in the COPD population. And I'd love, Natalie, if you could tell us a little bit more about the study design and the cohort used.
So this was another RCT, and like we said, comparing high flow nasal oxygen to NIV, to non-invasive ventilation. So the authors recruited individuals who had an acute exacerbation of COPD and had an associated decompensated hypercapnic respiratory failure that had failed to respond to initial medical management. They chose a non-inferiority design, meaning that they aimed to show that high flow nasal oxygen was not worse or would do no more harm than NIV, and had an accepted 10% margin. And the primary outcome was treatment failure. And it was, again, just due to the nature of this sort of intervention, an unblinded study.
Great. And I think another important study design with this non-inferiority design, I think we talked about it on prior journal clubs, but thank you just for noting that as we're thinking about how journal article 3 compared to this one, both looked at RCTs, but what was slightly different between them. And Chris, I'm interested to hear from you. What were some of the most meaningful results of the study? And particularly interested if there were any trends or secondary outcomes that you found particularly meaningful for day-to-day practice.
I think the first result to highlight was that the treatment failure rate in this trial was lower than they'd expected. They had a 15% treatment failure rate with NIV where they'd expected it to be closer to 20%. And that meant, unfortunately, that the power of the study was less than they thought it would be. Looking at the rates of treatment failure in the two groups, the overall average difference in failure in the two groups was not greater than that 10% margin, but the 95% confidence intervals was above the 10% overall. Again, speaking to that lack of power that I just mentioned there. So suggesting that there might be a benefit, but probably needing more data before we could really confirm that. In terms of other outcomes, they looked at a number of physiological parameters, and they saw that early on in the two treatment arms that the improvements in pH and PCO2 were greater with NIV compared to high flow nasal oxygen, but changes in vital signs were similar. On the benefits and the plus sides for high flow nasal oxygen, they saw that the patients with this therapy tended to report less breathlessness than those on NIV, so potentially it's more comfortable. And I thought a really interesting subgroup was when they looked at patients defined with having a mild acidosis, so a pH of 7.3 to 7.35, versus those with the more moderate acidosis of 7.25 to 7.3. In the mild group, they seemed to suggest that the treatment failure rate there was less difference between NIV and high flow nasal oxygen compared to the moderate group where the treatment differences were closer to that 10%. So that's starting to suggest that actually in that milder group that there might be more of a benefit. But I think that that's quite a caveated sentence because of that lack of power, really.
Yeah, thank you so much, Chris. And I think it's also when you're reading an article, you always want to apply it back to yourself, and would you change your current clinical practice based off the findings? So I think with this, not quite yet, but interesting kind of trends and notes that the authors can conclude. You alluded to some of this already, Chris, but any other limitations of the study that you think those listening should keep in mind, especially as you mentioned, it was good, there was underpowered for the primary outcome.
Yeah, so we've discussed that point, haven't we, around power, and that's really critical in that I don't think you can conclude that it's non-inferior from this study design due to that lack of power. It's not to say that it isn't non-inferior, it just means that you can't conclude that based on this data. I think the other main limitation, which I thought was the primary outcome, whilst on the face of it seemingly being an objective marker, is prone to some bias and potentially is subjective. So the primary outcome was treatment failure. So that's a clinician deciding that a patient needs to be intubated or to cross over to the other treatment arms. And in this sort of unblinded study, that potentially is prone to bias. So a particular clinician might be more in favor of one intervention over another and intubate where they wouldn't have in the other arm. So I think for this sort of study design, when it's unblinded, having pre-specified criteria for intubation, similar to the previous study where they very nicely, very tightly defined that desaturation criteria. And I think that's really important. And I think that is a limitation of this study.
Thank you, Chris, for your thoughts on that. And one final question for you, Natalie, on this study. How do you think high flow nasal oxygen will eventually take on a larger role in managing COPD exacerbations? Or do you think we're still a long way away from that?
I think we're probably a long way off that. I don't think that high flow nasal oxygen will take over from NIV. And I think what the study didn't look at was those patients who had failed NIV, how did they then go on the high flow nasal oxygen? And I think that's an important question to ask, because if patients fail high flow nasal oxygen, and particularly perhaps our more frail patients who mechanical ventilation is not a suitable or an appropriate option, there's really limited other options about what you can do in a patient with acute decompensated type 2 respiratory failure. And so I think there's a lot more research that's required. As we've mentioned, the study is underpowered, so it's hard to draw solid conclusions, but perhaps maybe you could say that if there was a patient who was really struggling with NIV on the ward, you could use high flow nasal oxygen, particularly if they were in that mild acidosis group, to give them some short breaks off the intensive treatment of NIV in that very supervised clinical setting.
Fantastic. Thank you for that and for the clinical relevance of this and how you may use it. Because I think those listening today are probably trying to understand how they could use high flow nasal oxygen. And as you specifically mentioned, in a supervised setting for the right patient with mild acidosis, this may be appropriate. We've had such a fantastic discussion during our time together today. Natalie, you picked 4 absolutely amazing articles to go through in more detail. And Chris, as we look forward to these continued collaborations with Pulm PEEPs and BMJ Thorax, anything you would like to share with those listening today about BMJ Thorax or Journal Club?
Yeah, no, really, it's just to reiterate what we've said already, which is that the main focus of the journal clubs is to highlight really high quality research from within roughly the last 12 months. They focus generally on a topic area like sleep and ventilation, as Natalie's has. And if people are interested in contributing to Journal Club, they're welcome to drop me an email. My email address will be on the links, and I can give you further information, and I'd be delighted to get you involved.
Awesome. Chris and Natalie, thank you so much for your time. This was such a fantastic discussions today. We look forward to more collaborations with you, Chris, and BMJ Thorax. And for those listening today, appreciate your time and really glad to highlight Natalie and the work that she's done. We'll see you next time on Pulm PEEPs, and thanks for listening today.